It's important to, once you've completed your polypectomy, assess the defect margins. The defect is the ulcer or the space that you've created by removing the polyp. And it's different for how you do that as to whether you're doing hot snare or cold snare polypectomy. As we alluded to previously, if you're doing cold snare polypectomy, the treatment of the margins is unnecessary or certainly is not evidence-based. Adding electrosurgical energy to treat the margins where you have performed an entirely cold resection without electrosurgical energy is almost nonsensical and has not been subject to randomized controlled trials. So we don't recommend it. But what we do recommend is that you take a wide enough normal margin to ensure that there is certainly no polyp at the defect margin in cold snare polypectomy. In hot snare polypectomy, the situation is a little different. Multiple randomized studies and observational studies have now shown that adding thermal ablation, so adding the effect of electrosurgical energy in a coagulation mode, normally soft coagulation, to the margin of the defect after your hot snare polypectomy can dramatically, fourfold in the majority of studies, reduce the rate of polyp recurrence at surveillance colonoscopy. And that's important because recurrence leads to surveillance burdens for patients, more procedures, more time off work, and increased cost to healthcare systems. You have your polypectomy defect, which might look a little something like this. You put the snare out a little bit out of the tip of the snare catheter, and then you, using the scope almost as a wand, leaning against the bed, you apply this kind of 1 to 2 millimeter rim of soft coagulation to the margin of the polypectomy defect. And this enables you to be very precise, and it enables you to, in the majority of situations, achieve complete ablation of the margin. And of course, at surveillance colonoscopy, this is going to decrease the rate of polyp recurrence for your patient and therefore decrease potentially the amount of surveillance procedures that they require. I think application of thermal ablation should be standard of care in polyps over 20 millimeters in size. Polyps of 10 to 20 millimeters in size, I think the jury is out because there is no evidence in that space. En bloc resections, so resections in one piece, the jury is also out. It's certainly true that in the largest observational study of this technique, the rate of recurrence after piecemeal resection of median size 35 millimeter polyps was 1.4%, and that very much equates to the rates of recurrence after ESD or en bloc resection. So it is unlikely that you need to apply this technique to en bloc resections, but it's safe and effective, and so if you want to, I see no particular downside. So in summary, cold snare resection, extending the margin of normal tissue excised, is the key factor to prevent recurrence and preventing and not making tissue islands. In hot snare polypectomy, clear all visible adenoma first, that's very important, and then apply a 1 to 2 millimeter rim of soft coagulation to the margin to prevent your patients experiencing adenoma recurrence during follow-up.